Thank you. Thank you very much, Dr. Maruk. I'm very grateful to the organizing committee for providing me this opportunity. Um, I'm not in the same league as Dr. Zakam Abbas, but you must know I'm standing in as a last minute replacement for our very worthy colleague, president of SOGPE, who could not make it because of last minute medical problem. We hope she recovers quickly. And that is why some of our gynecology colleagues are here for this lecture. So the talk that was allocated to me is HBV in pregnancy. This is a unique situation where we may be treating the mother, but also at the same time protecting the fetus. So we are preventing and the morbidity and mortality in later life for two people, which is a very unique situation. So it is important to remember some of the points that I'm going to mention here. I have no disclosures to make, and I bring greetings from my hometown with this beautiful picture of Lahore Museum. Now, I'm going to throw a case of a 23-year-old pregnant woman tested positive for surface antigen. Now, why did we check surface antigen in this patient in her first antenatal visit and then referred the patient to hepatologist? That's why I'm bringing up this case. Well, now all the guidelines recommend that not only B, but C should be checked as early as possible, preferably during the first antenatal visit of a person who is coming to the follow-up of our gynecology colleagues. So there is no doubt about checking surface antigen in pregnant women. What to do next? The gynecologists are not trained in evaluating and treating such patients. So such patients should be referred to a hepatologist, and that is why this patient landed in my clinic. So we have this patient, a 23-year-old young lady, surface antigen positive. We don't have any other data. What next? Well, when we say this, people jump onto investigations and treatment. The investigations certainly are needed. Whether you need treatment or not, we will discuss later. So these are just the basic investigations that are needed in patients with hepatitis B. So they are all required except thyroid function, liver biopsy, and those on the right side of your screen, and elastography or fibroscan. A word of caution here that in pregnancy, fibroscan and shear wave elastography give a higher value than what you should be expecting, and it returns to normal soon after pregnancy. So maybe not a good idea to check this during pregnancy, but if it is low, it is helpful. If it is high, you can minus 1 or 2 kPa from the value to get the correct figure. So these are just the basic investigations that we need for any person with hepatitis B and also in a patient with who is pregnant. So she came to my clinic, gave no relevant medical history of no previous pregnancies. She was just found to be surface antigen positive in the first trimester. I asked for some basic blood tests, platelets 175, INR 1, bilirubin 0.95, ALT 20. These are all very, very good so far. So nothing worrying here. So we must ask this question that why are we doing this exercise? The exercise has two purposes. Avoiding progression or decompensation of liver disease for the mother, and to reduce the risk of vertical transmission to the newborn. For assessment of liver disease, ultrasound, blood tests, transient elastography are needed. For assessment of liver disease E antigen, and DNA are some of the basic tests that you must not ignore. E antigen positivity indicates higher risk of transmission because of its ability to modulate the immune response if transmitted. And DNA, of course, now we have guidelines, so it is an important test. Here, this patient had a fibroscan which was 5.7, so nothing to worry about. Even if this is an absolutely normal value and no worries here. But the worrying thing here is the viral load. 1 into 10 raised to the power 6 international units. What does this mean? 1 million international units per mil. Remember, we are in the first trimester of pregnancy. Before we go into the prevention of mother-to-child transmission, let's talk about how should we go about treating potential or pregnant women who need treatment for hepatitis B. Well, ideally, or in the ideal world, pregnancy in HBV positive women should be planned, which never happens anywhere in the world. And one fine day, they come to you with the news that they have become pregnant and they are surface antigen positive. So remember this, that this never happens. If it happens, women with mild liver disease and low viremia should be treated before pregnancy, and their treatment should be completed. Women with moderate liver disease but no cirrhosis, again, treatment before pregnancy. If response, stop treatment before pregnancy. This usually applies that we are treating with interferon, which we hardly do these days. Women with advanced liver disease, you have to start treatment and continue treatment during pregnancy and continue treatment after delivery as well, because these women have advanced liver disease with all the indications for treatment, and that should be continued. Fortunately, we have drugs which we can use in pregnancy. Women with mild liver disease but very high viremia, so-called immune tolerant or hepatitis E antigen positive infection, these are the patients whom we are going to concentrate on in the talk. They should be given prophylactic nukes in the third trimester, although they are not candidates according to current guidelines. As our patient is less than 30 years of age, not a candidate for treatment according to current guidelines, but they should be given prophylactic treatment to prevent mother-to-child transmission. And as you can see, the EASL guidelines recommends all that I have said so far. The point that I have not mentioned, that in pregnant women, it is only TDF or tenofovir disoproxil fumarate that you should be using and not the entecavir. So if your patient is on entecavir, you are bound to switch it to TDF, and you should do that as soon as possible when you hear the news of pregnancy. This is FDA categorization of treatments in use of drugs in pregnancy. As you can see, talbividine and tenofovir disoproxil fumarate are category B drugs, which we would like to use. Talbividine is not available in many countries now, so it's not that we mention in treatment these days. Tenofovir is freely available, even free of cost in Pakistan. Tenofovir alafenamide, or TAF as we call it, is not categorized yet by FDA, but there is emerging data from many centers that it is safe in pregnancy. So if you go through the literature, I'm sure it's going to be categorized as B in future. So what about this patient now? We know that viral load is high. Liver is normal by all means. So what next? Again, we tend to jump to the treatment, but I would recommend that you educate your patient. You talk to your patient at this stage before, you have all the data now, before you embark on treatment. So you need to talk about the natural history. Well, I'll tell my patient, you have an absolutely normal liver with a very good outcome. Risk of transmission of HBV to baby and close contacts is there, and I'm going to talk about prevention of this later on. लाइफस्टाइल, जो मर्जी खाओ, जो मर्जी पियो, लेकिन कोई और इन्फेक्शन ना कराना, प्रेगनेंसी में हेपेटाइटिस ई ना करा लेना, इसलिए साफ पानी, साफ खाना. डाइट, नो रिस्ट्रिक्शंस. ड्रग्स, अल्कोहल, स्मोकिंग should be discussed with the doctor before taking. And of course, in this age, we are talking about vaccinations of COVID, HIV, flu vaccine, HIV, E virus, etc., etc. Family vaccination, there is a positive person in the family. All the close contacts should be screened and vaccinated if they are not already vaccinated. So this is an important aspect of management. Now coming to the other aspect of management, preventing mother-to-child transmission of HBV, it can be vertical, intrauterine, or perinatal. All of this is clumped into mother-to-child transmission. But most of it occurs perinatally, as we all know. This group of people here already know that. So what is the risk of mother-to-child transmission of HBV? Highest in E antigen positive, lowest in E antigen negative and anti-HBe positive. So again, it is important to do E antigen to stratify your patient. And this is if you don't treat your patient during pregnancy. How does it occur? As I mentioned, theoretically, all these routes are possible, but practically, it occurs perinatally. So maternal fetal microtransfusion during delivery and swallowing of infected blood is what really transmits the virus. Does the risk of chronic infection vary by the age of time of infection? Yes, the answer is yes, with a capital Y. Because if you are an adult and you get acute hepatitis B, the chances of going into chronic hepatitis B is hardly 5%. But if you are a neonate and you are E antigen positive as well, and you are exposed to hepatitis B, you get hepatitis B, the risk of recovery is almost negligible, and 90% of these will go on to develop chronic hepatitis B later in life. So again, it is important to monitor these babies and to treat the mother, and if it has not happened, to follow the baby and at least look after the new baby. How effective is HBIG and birth dose of vaccine and the subsequent course of vaccine in preventing mother-to-child transmission, and what are the reasons for failure? And that is why we are talking about treatment in pregnancy. Before we do that, let's look at what we are doing in Pakistan. In Pakistan, generally, we are recommending, according to the EPI, a birth dose and then 3 doses as a part of pentavalent vaccine at week 6, 10, and 14. So we are giving pentavalent vaccine at week 6, 10, and 14. Birth dose? Yes. We should strive for that because that is an important aspect in the prevention. The coverage is not very good, but the vaccine coverage, at least 3-dose vaccine coverage is quite good, around 60 to 70%. HBIG, well, only if the mother is positive. So it is not mentioned here because this is EPI. EPI is birth, 6, 10, and 14. So 4 doses of hepatitis B vaccine. Does it work? Well, you can have the data from Taiwan, where they started universal vaccination in 1984, and 2009, they found that those who were born after this period, the prevalence has dropped significantly from 10 to 0.9%. So it does work. It does prevent hepatitis B infections. And even in Pakistan, as you can see over the last 2 decades, with vaccination, the prevalence is coming down. When you look at the guidelines, they tell you that there is a certain level where you have to treat. Where does this level come from? Have you ever thought about it? Well, this is the landmark study by Wen et al., where, remember, this was in 2013, so we are talking about copies. And with when the copies of DNA are more than 6 log, it is simple to convert copies into international units. You divide them by 5 and you will get the copies. So 6 log copies means 200,000 international units. So this is the level beyond which the risk of transmission increases despite vaccination. If it is less than that, it is below 1%. So that is why, this is where the figure of 200,000 international units came from after this elegant study, that higher the viral load, particularly if more than 200,000, then the risk of transmission despite vaccination is higher. This is the category of pregnant women where you need treatment. And whatever treatment you use, lamivudine has been used in the past and TDF is used today. Whatever you use, the risk of transmission falls significantly. Otherwise, it is 2 to 20%. But if you use any drug, it falls. There are 2 studies published in the last 5 years or so where there is a negative study as well from Thailand. So, you must keep it in mind that there is a negative study as well published in 2018 in New England Journal of Medicine. But that doesn't matter. Now it is a standard of care to vaccinate, to treat pregnant women who have a high viral load. And looking at the EASL guidelines again, they clearly mention that DNA more than 200,000 international units. I won't talk about quantitative surface antigen because we hardly ever do it in practice. Starting at week 24 to 28 of gestation and continuing up to 12 weeks after delivery. Breastfeeding is not contraindicated in such patients who are continuing to use TDF for 12 weeks after the birth of the baby. All the guidelines, whether you look at ASLD, EASL, and APASL, carry the same message with different words and a few different endpoints. But basically, the message is the same. You start treatment week 24 and continue for 12 weeks after delivery. My 2 cents here is that don't start too late, because our patients have a very high viral load. The drugs that you are using do not bring the viral load down in 2 weeks. They bring it down by 1 to 2 logs per month. And also remember that pregnancy does not always last for 40 weeks. It can end at 34 weeks. It can end at 36 weeks. So for the message for Pakistani population is start as early as possible, because 1, viral load is high, and sometimes, unfortunately, premature delivery happens, and the drug hasn't had so much time to bring it down to safe level of less than 200,000 international units. So treat early rather than late. How often should these mothers be monitored? When you stop the treatment at week 12, well, hepatitis flares do occur. And there is data to suggest that 70 to 45% of women may experience as hepatitis flares. Most of them resolve spontaneously, and in this population, young, healthy adults, hepatic decompensation has rarely been reported, and this is supported by the data from the 2 recent studies that I quoted, published 2016 and 2018. One was a negative study, but as you can see, the flares were as were minimal, as common as with placebo, and it was rarely problematic. So there is evidence for this. Treatment stoppage, again, EASL is very clear, 12 weeks after delivery, and I think we are all should be following this. How safe is antiviral drug in this setting to the fetus when administered to the pregnant women, or to the infants when administered to the breastfeeding mothers? Well, there is no difference on adverse events on infants or in fetal development in this situation. So, breastfeeding is safe, use of these drugs is safe, and EASL clearly recommends that breastfeeding is not contraindicated in surface antigen positive mothers on TDF based treatment or on prophylaxis. So, in summary, ladies and gentlemen, hepatitis B immune globulin plus 3 doses of vaccine at birth is very effective to prevent maternal fetal HBV transmission, but higher maternal DNA is the key to failure. Recommended maternal DNA cutoff to TDF is 200,000 international units. This value or higher should be treated at 24 weeks of pregnancy and continued till 12 weeks after delivery, when it should be stopped. All such patients on stopping therapy should have a follow-up of at least 1 to 2 years for hepatitis B flares. Moreover, TDS is, or tenofovir disoproxil fumarate, is safe for both the mother and the fetus, and breastfeeding is considered safe on treatment. Thank you very much for your patient listening.